Good afternoon, everyone. Christina, on your end, would you be able to admit any attendee on the back end for us?
Absolutely.
Awesome. I'm going to get ready to start just because I know that we have a very small window and opportunity to speak on a really engaging and important discussion when we think about the intersectionality of behavioral health. So I wanted to Again, good afternoon, everyone. For those of you who may or may not know me, I'm Dr. Erica Pinthieff. I am the Senior Director of Training and Leadership Development here with Forge Health, and I welcome you all for, again, a wonderful afternoon discussion on the intersectionality of behavioral health and how, as clinical practitioners, we are to navigate race, gender, and identity when working with clients. To set us off or set the stage for our afternoon discussion, we will be highlighting and tapping into the framework of intersectionality. We'll touch into the systemic barriers within the healthcare system. We'll kind of go over some culturally responsive practices and evidence-based strategies. And then we'll kind of close out with some treatment plan considerations before we get into some questions and answers with some discussions. So when we think about the concept of intersectionality, for those of us who may or may not be familiar with the framework, intersectionality shows us that identity or one's identity isn't a single issue or a single access experience. People do not live their lives as just Black, just as a woman, or just LGBTQ. These identities lap and they influence each other in really complex and unique ways that really shapes how one experiences systems, oppression, and opportunity. Kimberly Crenshaw is the thought leader of intersectionality, and she really sought to explain how traditional frameworks that focus on one identity at a time really misses the full picture. And as a result, it really misses the people that are most marginalized by overlapping experiences of their identity. So when we think about introducing and incorporating intersectionality within our practice, it really invites and promotes us to reframe how we view identity, not as a checklist of traits, but as an interlocking system of experiences that really calls for more nuanced and responsive approaches, especially when we think about clients and access to behavioral health. So I want us to kind of set the stage and the framework of, as we kind of go through this discussion together, thinking about intersectionality as not as an additive of identity, but more so multiplicative, where our identities intersect to shape one's lived experiences. So I think a really good representation of how to best conceptualize intersectionality would be this particular Venn diagram template where we could understand how intersectionality plays a really paramount role within the lives of individuals. And for this diagram, we see how each circle represents one dimension of identity. So again, when we think about race, when we think about identity, when we think about sexual orientation, these aren't separate silos of identities. They interact and they overlap in our real lives. So I want us to think about a client that we may have had. And let's say, hypothetically speaking, this client is a Black transgendered woman. She isn't moving through the world as three separate identities, right? She's not moving in the world as just a Black person, a woman, or a transgender person. She's engaging and interacting in all spaces in her life as all of these identities at all of the same time. So the overlap that we see in the very center of this diaphragm, it represents that really complex lived experiences where multiple identities converge and they really produce distinct challenges or discrimination that necessarily wouldn't be visible if we looked at just one identity as a siloed alone. So I wanted to think, for example, again, as a behavioral health provider, we may understand racial discrimination. We may also understand transphobia, but we may not fully recognize how these combined identities uniquely shape our client's mental health experience. So that intersectionality, that bit in the middle, that's where a more holistic, inclusive understanding is really needed. So we want to make sure that we're recognizing that the overlapping of identities is really essential, because if we fail to recognize or account for how these identities intersect, we run the risk of not only diagnosing based on one lens, but we also may miss critical elements of a client's lived experience. So that's why, as we move throughout this discussion this afternoon, I want us to make sure that we are taking a really culturally responsive, trauma-informed, and more importantly, affirming care approach when we're looking to account for and take into consideration the intersectionality of our clients' identities. So kind of taking us a step back into the historical foundation of intersectionality. As I mentioned to earlier, Kimberly Crenshaw is the thought leader of intersectionality, and she was really critiquing how both feminist and anti-racist theories at the time failed to account for the experiences of Black women's unique experiences, where Black women specifically were being erased and where their specific experiences of discrimination weren't being addressed in either movement, right? They weren't being addressed in the women's feminist movement. They weren't being addressed in the anti-racist movement. So she really looked and sought to argue how legal and policy frameworks, as I mentioned earlier, were really single access and viewed identity really as a siloed approach, which often addressed race or gender, but not both. So when we're thinking about how this particular framework applies to behavioral health, and again, as Kimberly Crenshaw introduced this concept as it related to policy work, legal work, we had scholars and researchers and policymakers that were looking at how do we expand this notion or this framework of intersectionality and apply it to behavioral health. And it really was looking at how do we expand it to healthcare by emphasizing how both gender and social determinants intersect with health inequities. And we were finding a lot of health researchers, policymakers, and practitioners began to really acknowledge that not only was race and identity important to account for, but we were also looking to expand that discussion when it came to class, when it came to income, when it comes to education, when it comes to ability, when you think about invisible or visible disabilities, when you think about health, when you think about age, when you think about immigration status. So all of these different experiences and different identities, they wanted to really better conceptualize and respond to issues of healthcare and the differences of the experiences between men and women and how it was shaping their lives when it came to health. So when you're thinking about intersectionality and behavioral health, we're recognizing that it's valuable to normalize that the intersectionality of one's identities do have a profound, complex impact on one's access to health equity. So before we kind of get into some of the systemic barriers in healthcare, I'm actually really curious to the audience, if you were to think about traditional models of healthcare in your own professional experience, can you think about an opportunity or an area where it may have fallen short in addressing the needs of clients with intersecting marginalized identities? So if you were to, so again, just to kind of think of from your own professional experience, how has traditional models of healthcare fallen short in addressing the needs of clients with intersecting identities? So I think, one of the things that I may have shared with some of us in the room is that I have a background having worked in community corrections for several years. And in my experience having worked in corrections, I've actually seen firsthand how traditional mental health systems and even the broader justice system in particularly have failed people who struggled with undiagnosed or misdiagnosed mental health conditions, and particularly from marginalized communities. So many of the clients that I experienced or I worked with that were living with serious but untreated disorders such as bipolar, PTSD, schizophrenia. But instead of it being viewed through a trauma-informed or a critical-informed lens, their behaviors were often seen as defiant, aggressive, or even manipulative. So the response from providers and practitioners was not more so of a supportive or a helping lens or perspective, but more so from the lens of punitive. So when I speak of punitive specifically, I'm speaking on solitary confinement, loss of privileges, or even extending one's incarceration time. So rather than having an approach of more of a holistic, clinically trauma-informed perspective that is supportive, it was really faced with more so punitive action. So, when I'm asking the audience of how has traditional models of mental health care fallen our clients, that's just from my own personal and professional experience. But again, I'm actually really curious from the audience, from your own background, can you identify any moment in time from your professional experience where it may have failed clients? Okay. Awesome. Thank you. If you want to share anything, though, also include it in the chat, or you can also drop questions. So getting into some systemic barriers in mental health specifically, when we're looking at barriers to access to behavioral health, we're also moving into highlighting barriers including cost, barriers of a lack of culturally competent providers, some geographic isolation, more so specifically when you think about healthcare deserts, as well as cultural or societal stigma. So really taking into account and reflecting back on some of these systems that clients are navigating. These are systems that often mirror the bias and exclusions of society. So limiting access for even many more marginalized groups. So kind of deep diving a little bit when we think about lack of culturally competent providers. Many providers aren't trained to understand or engage with diverse racial, gender, or cultural identities. So this often, unfortunately, leads to misdiagnosis, biases, and care that feels really invalidating or unsafe for clients. And we find that sometimes their symptoms are often pathologized, of contextualized within cultural or racial trauma. When you're looking at or thinking about structural racism and economic inequity, historical and ongoing systemic racism results in unequal access to insurance, to access to quality of care, as well as behavioral health facilities. So when you're looking or you're thinking about low income, rural, and BIPOC communities, these communities often face underfunded clinics, incredibly long wait lists, or again, to my earlier point about healthcare deserts of geographic isolation from services. So, structural inequities lead to chronic undertreatment or a completely lack of treatment altogether. And then lastly, we're looking at stigma and discrimination within the systems. As we know, mental health stigma is intensified for those who are marginalized by race, gender identity, disability, and even immigration status. And clients may even fear being judged or misunderstood or having their identity again pathologized, leading to again under or misdiagnosis and a lack of treatment. And we find that discrimination within any of these systems, again, being misgendered, stereotyped, or ignored, often causes mistrust and unfortunately disengagement within our services. I did have one question actually before we get into the impact on marginalized populations. Can anyone in the audience think about what barriers possibly exist within our own communities that might limit access to gender affirming or culturally affirming care? Guy, I think I see that you're on, Guy. If you're near the screen, as a medical provider, do you have any thoughts in terms of what possible barriers you may have experienced in your discipline in terms of access to care? And I do see Bertha. Thank you so much. I'll tap in with you shortly. Um, Guy, if you're around or not, Dr. Mital. Okay, as I wait for Dr. Maytal, I'm looking at Bertha's comment, a therapist who speaks the language of the potential client. Bertha, if you don't mind, if you could unmute yourself, what do you mean when you say that a little bit more?
Okay. Okay, thank you, Dr. Erica.
You're
So
welcome.
I have noticed, or I've had clients said that if their primary language is maybe Polish or
Mm-hmm.
Spanish, or
Mm-hmm.
if you have someone Haitian, if they speak French,
Mm-hmm.
like coming into seeking assistance or seeking therapy and
Mm-hmm.
not having someone in that particular community that could, address and speak that language that they're more comfortable. They may speak English as well, but they're more comfortable speaking their native language.
Mm-hmm.
I don't
Mm-hmm.
know if that actually speaks to what you're referencing to.
No, you're absolutely right when you think about the comfortability or the cultural competency of a provider, right? There is value of having some shared identity or shared groups, right? And I think it's also interesting too when you're thinking about the linguistics of the provider. Also, are we able to communicate these Western ideologies that we have of mental health, though some of our words or the terms that we use as practitioners, sometimes they're not always translatable to the native tongue of our clients too. And the value that clients find in meeting and being with a provider that does speak the same language. That you're 1,000% correct. Thank you for sharing that, Bertha. Any
I'm
other
sorry.
thought? Oh, go ahead. I'm
I want
sorry.
to say, Dr. Erica, thank you. I apologize. I had an experience and I found it very interesting. I had an experience a couple of weeks ago where
Mhm.
there was a client who came in referred by the VA and was
Mhm.
visually impaired,
Mm.
and how challenging that was for us to try to navigate that, because per our ROI, it says we have to read the ROI, the one that's like 15 pages long. So we
Yes,
have
yes.
to read
Oh, that clinical, you mean the clinical service agreement?
the clinical cert. Thank you, doctor. And it says that we have to read each
Yeah.
page
Yeah.
to the client if they're visually impaired.
Yeah.
And when I tell you it was a task at
Mhm.
hand, it was, I think, not only maybe traumatizing for the client, but
Mhm.
also for me as the clinician. And I had some assistants to go through and read that. And I think that was a barrier
Mhm.
for that situation, because we
Mhm.
kind of didn't have anything really in place
Mhm.
to
Mhm.
kind of know how to handle if
Mhm.
we're getting, per the American Disabilities
Yes.
Act, we
Yes.
cannot, like turn the person away or
Right.
deny them. So to
Correct.
navigate that, so I found that as a barrier
Mhm.
that we recently in Princeton had to, we were faced with and
Right.
tried to navigate through.
Right. And thank you for sharing that, Bertha. And I think, highlighting that as a possible barrier, right, with the client when we highlighted earlier the visible or invisible disabilities of clients, right? So for someone who is visually impaired, and what are the support systems that we have in place so that we do not inadvertently as an organization, as a clinic, create a barrier. And I want to commend you, Bertha, on the fact that you did take the time, as patient as I could only assume that you were, in going through and reading through the document. However, that was also an opportunity as an organization where we could take a beat and a step back when we speak on and we amplify that we are culturally competent, we work with specialty programming, et cetera, et cetera. What are the systems and how responsive are we now going to be and proactive in making sure that when we are, again, marketing and branding ourselves as an organization that creates not only quality access to healthcare, but we're also dismantling any possible barriers to access to healthcare, regardless of the disabilities, whether it's visible or invisible. So thank you again, Bertha, for sharing that experience. And again, I certainly want to commend you on you being patient enough to walk through that with the client, because getting through a clinical service agreement for the client to legally attest and be against to permit treatment to receive treatment for us is a heavy lift. So I do want to acknowledge and I thank you for that, Bertha. Any other thoughts of any oh, well, thank you, Bertha. Any other experiences from anyone's background or professional background about what are some other possible barriers that exist within our community that may limit access to culturally affirming healthcare with clients? Just going through the chat as well as all of the face cards. Awesome. So as we get ready, and again, thank you, Bertha, for sharing your experiences of recently with that client in Princeton's location. I kind of want to go through the impact of systemic barriers to healthcare that it has on clients that are a part of or are members of marginalized communities. So really looking into the effects of systemic barriers are not necessarily felt equally. Marginalized populations do face compounded impacts that shape their mental health risks, their experiences of care, as well as their treatment outcomes. So when we're thinking about compounded trauma and chronic stress, literature suggests and the research does show that marginalized groups often face multiple layers of trauma. So we're talking about generational trauma, racial discrimination, gender-based violence, as well as economic instability. And all of these stressors, regardless of what bucket they fall under, it really does increase vulnerability to mental health conditions. So we're talking about depression, anxiety, PTSD, as well as substance use. And this is often misunderstood or also overlooked by providers who may be unfamiliar with the cultural or systemic trauma. And again, I really want to speak to and highlight my earlier disclosure of having worked in corrections, where the clients that were undiagnosed, misdiagnosed, it was often perceived as being, again, more of an underlying or underpinning of criminogenic attitudes and behaviors, as opposed to being met with more self-supportive resources from providers. Also looking into the mistrust of behavioral health systems. Historically, we know that some of our systems that are systemic and systematic, there are discrimination to healthcare that has led to incredible mistrust among providers as well as institutions. A great example for anyone who is or may not be familiar is the Tuskegee syphilis experiment. And from those experiences, from not only a vicarious trauma, this leads to delays or a complete avoidance into seeking mental health services, even when clients are in crisis. Reduced engagement and poorer treatment outcomes. When care is not culturally relevant or identity affirming, clients are more likely to disengage from services, and this results in higher dropout rates, underdiagnosis, or misdiagnosis among marginalized clients. So, if we want to make sure that the fit between provider and clients leads to effective treatment, as well as a reduction in any re-traumatization or even harm to clients. Looking into how do we as providers provide culturally responsive care that is trauma informed. So when we're looking at bringing together trauma informed care as well as cultural responsive practices, we as providers do create a space where clients feel more emotionally safe seen as well as empowered. And these approaches just not just reduce harm, but they also transform the therapeutic experience. And that looks like the building of trust and safety. So culturally responsive care really signals to clients that their identity and their lived experiences are respected, which helps reduce the fear, the shame, as well as any guardedness to the therapeutic process, as well as to access to healthcare. And this is really critical for clients from communities that have historically been harmed or excluded from the healthcare system. When we're looking at improving client engagement and retention, when clients see themselves reflected in the space through affirming language, representative staff, and identity-aware questions, they're more likely to engage in care and stick with it. And I think, Bertha, you're sharing earlier of a client who was Polish, was able to find a provider that also spoke the language. That is all affirming practices within, as nuanced, as small as we may perceive it, but has a very profound impact on the client experience. And then we look at reducing the risk and harm or re-traumatization with clients. As we know, and we've kind of highlighted throughout our discussion together, traditional care models can unintentionally replicate dynamics of control or invalidation and even judgment. Especially with clients who may have experienced systemic oppression or identity-based trauma throughout their lived experiences. And having and incorporating trauma-informed, culturally responsive care, it really seeks to empower the client, offers choice to the client, and recognizes the context of their distress rather than blaming or labeling and even pathologizing their symptoms and presentations. So, what are some strategies for practitioners when we're looking to navigate complex identities or intersections of identities and really leaning heavily into the skills that we already have when you're thinking about the use of open-ended and identity-affirming questions? So, this is really important where we're looking to avoid assumptions. We're looking to avoid assumptions again about the client's identities, their backgrounds, and more importantly, their lived experiences. So using open-ended questions, again, with the use of motivational interviewing, which we'll talk about in the next upcoming deck, is we're looking to invite clients to share what's most important to them in their own words, and it centers the client as an expert in their own life. And oftentimes, when working with clients and even working with staff, I often share that we as providers are not that expert of the client's lived experience. We may be experts of many things, right? When you think about the clinical lens or perspective that we have as professionals, but when we think about the expert of the client's life, that we are not. So being able to again utilize and lean into open-ended and identity-affirming questions, it really centers and prioritizes the client as the expert of their own lived experiences. Looking to adapt materials or services that reflect the communities that we serve is a huge tips and trick when we think about a strategy. So we recognize that representation matters. So looking to review any of our handouts as in our clinics, any visuals, any websites or resources that we have for our practice, and really sit and consider, do they reflect the racial, cultural, and gender diversity of the clients that we service? And being able to provide materials in multiple language, ensuring accessibility. And again, Bertha, you were spot on with your disclosure earlier. Is as an organization, as a clinic, are this all the tools that we have equitable to everybody, every possible client that we may provide service to? And it's either going to be a yes or a no. And if there's a no, there's always possibility to grow and improve in that area. So definitely as a clinic, as practitioners, tailoring our outreach and engagement practices to meet the clients where they are, both culturally and geographically. And lastly, not to assume sameness. And that's really important when we think about having shared group identity, right? As a Black woman, as a LGBTQ community member, as an immigrant, right? Shared group identity, because every client's story is unique. So although we may have a shared group identity, we do not have a shared group experience. So we want to make sure that we are avoiding stereotypes, or this one size fits all framework, that really erases the complexity of one's lived experience. And by doing that, we're able to validate the client specific realities. So I'm just curious for anyone in the room, and I see some. Hold on, I'm so sorry because I'm trying to navigate all of the windows. Amy, I see that you dropped something in the chat. And Dr. Cleo, I'm going to tap in with you afterwards. But Amy, would you mind sharing what you shared in the chat of your experience having worked in corrections?
So, hi everybody. Yes, I worked in corrections in Philadelphia for almost 4 years and I loved it, but it was challenging
Mhm.
nonetheless. Just because I think there is this just stigma still. So I think that was part of it. Access was also really difficult, just
Mhm.
accessing the IPs, the incarcerated persons.
Yeah.
Um, Trying to work with corrections to get access to them, to have them get access to us while also maintaining safety. So it was just a challenge when it came to that, and then being taken seriously. Because right, looking at secondary gains and all of that,
Mhm.
housing, things like
Mhm.
that. So yeah, it was really tough just being able to provide like care and support in that type of setting. Again, safety is number one there, but it was just, yeah, it was
Mhm.
really challenging. So,
Of course. And that delicate balance in navigating not only our personal safety, working in that environment, but also doing right by the client, right? Of making sure that their symptoms, their presentations are really viewed holistically,
mm,
culturally appropriate, so that their experiences, their symptoms are not either going undiagnosed,
yep,
misdiagnosed, and they're not perceived, again, to my earlier point of any maladaptive criminogenic attitude or behavior, right? Manipulative, aggressive, which then leads again to those, removal of privileges or
of course.
punitive
Yep.
measures.
And they go to segregation and they lose all of that. Then they're in for multiple days at a time.
Mhm.
So yes, it's just navigating that and realizing that we also had a job to do as mental health providers, and
Absolutely.
we all have licenses that we need to uphold. So that is also important too. Listen, we need to do our job. So
Mhm.
I loved it, but it was, yeah, definitely that balance of also making sure corrections doesn't get mad at us and we work
Right.
with them.
Mhm.
So there were a lot of parties involved to make sure we
Different
are
people, places, and things that have a very different perspective and the lens in which they're coming into the table with.
exactly.
Everyone's priorities are their school of thought,
Yep.
their priorities are very different. And
Mhm.
how do we as the provider kind of navigate all of
Okay.
those, and take into consideration all of those pieces together? Thank you, Amy.
Sure.
Dr. Cleo, I saw that you dropped something into the chat. Did you want to speak to your experience also serving on the board in Virginia?
Yeah, it's the same as what Amy was talking about, that unfortunately that population is misunderstood a lot or not heard. When they are crying out for help, that, a lot of times they're not believed. And so unfortunately, what I've seen in Virginia is that the highest rate of deaths are from unaddressed mental health concerns. And when we look back at the records, it's not that they didn't raise their hand or they didn't ask to speak to a medical officer or be, sent to the medical unit, and it starts off as physical symptoms.
Right.
But because nobody actually stopped to say, like, what are you feeling? Is it heart palpitations because of you're scared of a court date coming up, or do you really like, is it real? And so I don't know. It just reminded me. I agreed with Amy that it's unfortunate, it's difficult in that situation. Um, but there it can be better. So when you do have conversations with the correction officers about like, I know safety is number one, but also these individuals are in your care. And what does that look like? Like we're not expecting you to be a therapist, we're not expecting you to be a mental health professional, but at least pause and try to hear them out. And if there's any doubt, if there's any sort of like this person actually might need some help, it doesn't hurt to go ahead and put in a referral to see a nurse or a mental health professional and so forth. But yeah, it's, that population is one where cultural sensitivity is not necessarily the number one thing in that setting. Everybody's trying to look out for safety first.
Right. That unfortunately in those settings, it definitely is, that is the priority, is that everybody who goes to work actually gets home safely. And then what do the other priorities kind of look like after that fact? Mhm. Thank you both for sharing that from your experience. So kind of going into not only strategies for practitioners to adopt and use, but also looking into some evidence-based approaches that we can incorporate within our practice as well. Now, I know cognitive behavioral therapy is one of the things and is widely used. However, a derivative of CBT is a culturally adapted cognitive behavioral therapy. And we see the impact that CBT has on a client's treatment outcomes. But when it's applied without cultural adaptation, it could actually miss the mark for clients of color, immigrants, or even marginalized groups. So looking into culturally adapted CBT, which modifies language, metaphors, values, and even therapeutic content to best align with the client's cultural content. And these adaptations, again, and we've talked about this earlier on in our discussion, it not only builds trust between the client and the provider, but it also increases the relevancy of the modality we're working with this population, as well as improving client engagement and treatment outcomes. So, for example, we may want to include discussions of racial trauma or community-based coping strategies in therapy for marginalized identities of clients. When we think about community-based and peer-led interventions, leaning on trusted messengers like peer support specialists or community health workers, this could help reduce stigma as well as foster a sense of belonging with clients. And these interventions are really grounded in a community knowledge and a lived experience that often addresses social determinants of health alongside therapy. And then also looking at how community-based approaches improves retention and satisfaction among clients by providing care that is non-institutional as well as in familiar environments. And lastly, and we touched on this earlier when we think about motivational interviewing with the use of open-ended questions. MI is a phenomenal intervention and approach when we think about it is client-centered, it is evidence-based, and it really does respect the client's autonomy and helps them navigate ambivalence around change. And when we use cultural responsiveness, we're honoring family values, we're honoring religious beliefs, as well as any cultural concepts of wellness. So it really does, again, move a little bit away from just the traditional behavioral healthcare model of that is westernized, but really looking at what are the cultural family dynamics, cultural norms of clients, and how do we incorporate that in the client's treatment to make it really unique to their own experiences and values and honors their background. So MI can help build not only a stronger therapeutic alliance, but it also empowers clients without judgment. When we think about the pathology of mental health systems and how they invalidate and or misdiagnose or undiagnosed clients throughout the system. So definitely being able to utilize MI and adapt it to the client's needs, context, as well as within the framework of their family dynamics, as well as their traditional cultural norms. So I'm curious, as we think about approaches, strategies, as well as evidence-based approaches for all of us in the room, what modalities or interventions have you found to be the most impactful when working with clients of intersecting identities? And I'm really curious of its impact that you have found as a provider and its impact on the client's treatment outcome. So I think I'll share. I actually recently have a client that I see and work with in private therapy or in private practice, and she identifies as a Latina. She is Puerto Rican, and she's also Salvadorian. So for anyone who's familiar or unfamiliar with anyone from a Hispanic or Latino background, that community historically is historically is collectivistic and communal. So which means that she lives in a multi-generational household. So she has her grandmother, she has her aunt, she has her uncle, she has her parents, and she also has her younger siblings that all live in the same home. And it's interesting when we have conversations, and more importantly, what's bubbled up into therapy is the use or the establishment of healthy boundaries in these relationships. So as a practitioner, I'm navigating not only understanding the influence of family dynamics and cultural norms within the household, but also respecting the client's autonomy of wanting boundaries or wanting to establish a boundary. And how do you do that when your mother's all up in your business? How do you do that when your sisters are calling you when you're on dates with your partner? How do you do that with, your uncle who's looking at the time of when you're coming in or what time you get off of work to come back in the house? So it's a really interesting dynamic of really not only honoring the goal of the client of establishing healthier boundaries in these relationships, but also taking into account and consideration that there are cultural norms and family dynamics that are simultaneously at play. And as a provider, I need to delicately walk this balance of honoring and being patient with the client's process while also how she's navigating the attitudes or behaviors of her family members when they're noticing that these boundaries are being implemented. And Dr. Cleo, I see that you dropped in a chat of gender affirming care is an evidence approach to use that respects one choice. That you're absolutely right. Did you want to speak a little bit more about that, Dr. Cleo? Or can you, I should say, can you speak a little bit more about that?
Sure. Just when you asked, like, what's an evidence-based approach that we can use based upon someone's kind of cultural identity, one is gender affirming care. So accepting one for who they are when they present to you and not trying to convince them that they should be one way or the other. So that is sort of just generally gender affirming care, accepting one's choice as they present to you.
Absolutely. That's really good. Thank you, Dr. Cleo. And I know gender affirming care works really well when we think about clients in our LGBTQ communities. And again, respecting the client's process, respecting and honoring the progress that the client is making in therapy, because although it may be what we may deem as small efforts, those are really big, impactful efforts that are working on with the client and their lived experiences. So definitely honoring and respecting those. Thank you, Dr. Cleo. Any other thoughts of when we think about strategies for practitioners, as well as any other evidence-based approach that you have found in your own practice that has been impactful working with clients with intersecting identities? Okay. Awesome. So, in thinking about as we wrap up our discussion for this afternoon, I really wanted to really emphasize and impress upon us of the framework of intersectionality really helps to reveal hidden dynamics within the healthcare system. So recognizing that clients that may be struggling with mental health are really shaped by overlapping systems of oppression. So again, moving just beyond just race and gender, but thinking about sexuality, thinking about visible and invisible disabilities, thinking about class, socioeconomic status, age, all of those things are playing a role with informing how the client is navigating all of these systems and how their identities are intersecting. So really looking into how intersectionality really helps us see the whole person. And again, Dr. Cleo, you just shared earlier in terms of like respecting and honoring the client of how they're presenting to us in that time. So really seeing the client as a whole person, especially those whose needs are often overlooked by those single issue frameworks. So, and taking into account that intersectionality allows us as providers to not only recognize root causes of distress, but also the symptomatic presentations of those as well. Looking into the systemic change and personal reflection are both necessary for equitable care. Looking at how achieving equity and behavioral health means transforming systems. So systems, I want us to think of broadly in terms of policies, practices, and training, and being able to do the internal work of examining our own bias and blind spots. And again, I think I mentioned and highlighted this earlier that I commend all of you for attending our training this afternoon, because this is what becoming a culturally competent and inclusive provider looks like, is being in spaces with other practitioners and sharing from their own lived experiences, while also learning some new information and prompting us to further research and apply those findings within our own individual practices with clients. So it really is recognizing that it's not enough to want to help. We have to ask who's being left out and whose voice is missing, because recognizing that change happens when we're willing to hold ourselves and the systems in which we work in accountable. And again, Bertha, I'm going to keep highlighting your disclosure earlier, is that this is an opportunity for us, not only as individual practitioners, but also within larger systems and organizations, of how do we equitably hold ourselves accountable when making sure that we are implementing changes to ensure that access to healthcare is importantly equitable. And then lastly, looking at our goal is not just access, but also inclusive and affirming care. So true equity isn't just about opening the door for clients. It's really about making sure that our clients are feeling welcomed, they're feeling respected, and they're also feeling empowered when they walk through our doors. Affirming care recognizes the whole identity of the client and really adapts to meet their individual needs versus this one size fits all siloed single issue framework that other people, places, and things may not account for or include in their practice. And also recognizing that inclusivity means making sure that safe spaces are effective for everyone, especially those who have been impacted the most by systemic or systematic and systemic harm. And I think I see a comment in the chat that I wanted to highlight is, Amy, you shared being open to learning about others, asking open-ended questions, and also apologizing if we get things wrong can go a long way. Thank you, Amy. Bertha, I do see your hand up. Did you want to share?
I did. Thank you, Dr. Erica. And I will probably piggyback off of what Miss Amy just shared. I have a client, when I did the onset of his assessment, he was saying how he thinks people are following him, and every time he look around, there's police officers around, and you know, I think someone is going to try to snatch me up, and I thought at the onset paranoia,
Mhm,
maybe delusional.
mhm,
But as I continue to work with him, I found that he was a DACA immigrant. And right now his status is pending. And because of the political climate and things that we have been hearing, and he's a student, he just graduated this month in May from Rutgers, where
mhm,
students are being stopped. They are being taken into custody. I
mhm,
don't know if anyone heard, as a student was um, remanded into custody after going to an appointment, you know, at the immigration office. So I had to apologize, well, to myself, because I didn't say to him, I think you're paranoid, but
mhm,
I began to understand
mhm,
like this was an actual systematic
Mm-hmm.
situation that he was
Mm-hmm.
dealing with. And there was
Mm-hmm.
some validity to the
Mm-hmm.
concerns that he was sharing and what was going on.
Right.
So I just wanted to share that. Thank you.
No, I really do appreciate you sharing that, Bertha, and you're 1,000% right. When we're looking at any of the things in which a client is disclosing or sharing with us from a very single lens, we then just default to, oh, yeah, the client must be paranoid. They may have symptoms or presentations of schizophrenia, et cetera, et cetera, et cetera. Meanwhile, the client is actually experiencing some visceral traumatic response, right? Because vicarious trauma at that, because he's seeing people, places, and things, whether it's through the media, whether it's through his own lived experience with people that he may know that are being detained without fault, right? Without any criminal behavior to substantiate the detention. So, thank you, Bertha, for even recognizing and apologizing to yourself, number one, because we don't, as providers, we don't have it all in terms of all of the answers. But the humility about that and about us is that we're always open and receptive to learning and doing something differently than we've done before. So thank you, Bertha. Thank you for sharing that. Thank you. And then I also see, Dr. Cleo, you had dropped in the chat narrative therapy, where we allow people to just tell their story, allows us to understand better. And she tagged you, Bertha, nice example of allowing the client to tell you their story so you know how to help. Absolutely. And both of those speaks to recognizing that the client is the expert of their lived experience, and that we need to have a better idea of taking a step back to allow clients to really speak to what their own lived experiences are, and they then inform us on how to best support them moving forward. So, as we get ready to wrap up our training this afternoon, I did want to take a few minutes to see if there were any questions that anyone may have had throughout the duration of the training before we wrap up this afternoon together. Let me actually stop sharing my screen. Awesome. And I'll go through the face cards really quickly to see if there are any questions, comments, hands up, or anything in the chat before we wrap up this afternoon. Okay, awesome. So I do not see a hand. I do not see anyone off of their camera screens. So I want to, as we get ready to wrap up this afternoon, again, I want to thank you all for taking the time to learn about the intersectionality and the framework of intersectionality and its application within the behavioral health space. And even this engaging discussion and dialogue when we think about systems that are systemically oppressive to marginalized communities, marginalized identities, and how all of these identities have a very complex and profound informing of a client's lived experience, and more importantly, just kind of taking away some tips and tricks of strategies, as well as some evidence-based modalities that we can lean on and leverage when we're looking to improve our own practice when working with clients. So again, I thank you all for taking the time out of your Friday afternoons to briefly connect together. And if you have any questions, you all know how to get a hold of me. Please tap in with me. I'm always available and accessible. And I wish you a very happy Friday and a wonderful weekend, everyone. Thank you.
Thank you. You as well.
Thank you, Bertha. Bye, everyone.